So welcome to the September Clinical Pathological Consensus Conference. Thank you to Sonia Anderson for putting together the PowerPoint. Thanks to Shuling Pfister for making these nice photographs. I think many of us recognize this. I believe this is this picture from the Natural Bridge down at the Gorge. We always perform this conference in the spirit of profound gratitude and respect to the research volunteers who are our partners in this enterprise of trying to get together as a team and defeat these horrible dementia illnesses. And we try to perform this conference in the spirit such as we would if they were right here and their families were right here with us in this conference. And in a sense, they are. And with that, we will start with participant ADRC ID number 2086. Dr. Koskin, take it away.
Okay. So we have 86 years old, Caucasian right-handed with a ApoE genotype of 3-3. Past medical history is significant for hypertension, hyperlipidemia as vascular risk factors, as well as TBI with loss of consciousness. And then there are other things as depression, and you can see the rest of it. So this person is entered in our ADRC cohort in 2020 with the wife's request. Apparently, he didn't really want to participate in. But the diagnosis was multi-domain MCI at the time when he was entering it, and then progressed to dementia by year 2. So his course was gradual decline in memory and executive functions. Eventually, he lost the first IADLs and then ADLs, which then mood and effect blunted over time. So it seems like the course of the disease actually started with the cognitive features and behavioral issues, as the amnestic with the early distractibility and executive dysfunction, as well as visual spatial issues as driving problems. And in the same time, he had some agitation later years. He developed irritability and depression. Until the last year, actually, he didn't have hallucinations, but reported as hallucinations in the last year. So the motor symptoms actually in between those two, after the cognitive issues started, he had some frequent falls and balance problems, but the exam was not really showing any Parkinsonism. Basically, exam was non-focal throughout the years and with some gait imbalance. So over the years, we tried actually memory medications, but he wasn't able to tolerate because of the GI issues. So his management actually was done by the SSRIs. All the consensus, the reports find it as Alzheimer's disease with vascular contribution. I'm sorry. So the consensus, the diagnosis was considered as Alzheimer's disease with vascular contribution. So other ones that could contribute in his the progression is possible undiagnosed ADHD and depression. So the final EPIC entry that I found with the presented with the left MCA stroke versus bilateral ICA stenosis with the right-sided weakness and speech disturbance and worsening behavior. So it sounds like either stroke or symptomatic stenosis in the great vessels. So the last days of the patient's the patient's life was spent in the inpatient hospice care. So we don't have, unfortunately, any images, except that since he presented with the stroke symptoms, there is CTH and a bunch of other things that I saw. Basically, from that report, we can see that he has mild generalized parenchymal atrophy, as well as some mild white matter disease. So final diagnosis is most likely mixed dementia due to AD and vascular disease.
Thanks very kindly, Dr. Koskin. Dr. Harp, this is a person who's 85-year-old male who comes in with impaired and goes down with dementia. Anything else to add to it?
Yes, so he started with an MMSE of 21, entered with MCI/dementia. At first, he showed low story learning and figure recall, along with low trail speed switching, which is speeded executive functioning. His verbal fluencies were borderline. Over the next year or so, the rest of his memory, visuospatial speed, and his animal fluency decline. He does show fluctuation in visuospatial function and figure recall over time, and then he has global impairment by year 4. So this presented some interesting things to us. It does seem primarily to be that he has an Alzheimer's disease with vascular contributions. A couple of things we found interesting were the hippocampal sclerosis type pattern that suggests possible late involvement from the beginning. And then he also had that fluctuation in visuospatial function, which can point to an alpha-synucleinopathy. His final MMSE was a 0.
Okay, so this 85-year-old male comes in and 5 years with MCI, and 5 years later he passes with dementia. His pathology shows severe Alzheimer's disease as well as dementia with Lewy bodies, but no late at all. There was acute and chronic vascular changes, so it was an A3C2. So this is AD plus DLB with the vascular contributions as well. Looking at the digital readouts, the severity of tangle pathology was almost enough to give a BROC 6, but not quite. So this is BROC stage 5. The severity of and the distribution of A beta amyloid was Thal phase 5. So this is as severe as it gets for A beta amyloid. And so a high level of AD, intermediate level of Lewy body pathology, and cerebrovascular change as well. So we wanted to, so this is where this person comes in our schematic Venn diagram motif that conveys the overlapping, many times very complex pathologies. I guess this person would also be over here in cerebrovascular. So this person had a number of different things that contributed to this multimodal symptomatology through a multimodal pathology picture. Just to round up, these are the digitized AI recognized and quantified neuropathology, and we're going through some changes currently in how we do this. I'm going to have this explained by Dr. Ryan Shahidapur, who has sort of a double life. He's a killer athlete. This is him in his lacrosse garb. He's also going to be representing our country in the international strongman competition. But on the right, you can see the mild-mannered neuropathology-focused postdoc who is a genius and guru in digital neuropathology. And with that, I will have him take it away to describe some of the recent changes we're making with our digital pathology goings on. Dr. Shahidapur.
Can you all hear me? Let me go ahead and share my screen. Thank you for all of that added pressure. I'm not at all nervous now. Can you see my screen?
No.
How about now?
Come on. Double click to enter full screen mode. There we go.
There we go. Okay. All right. So for the sake of time and brevity, I'm going to be kind of flying through this. But as Dr. Nelson said, not only are we transitioning into a new physical space, but the way that we kind of assess and analyze our digital pathology is also going through a large shift as well. So I'm going to kind of give you a look behind the curtain.
Speak a little bit louder, Brian. Could you please speak up a little bit?
Better?
Yeah, just speak up.
Okay, so in addition to the shift we're making in Sanders Crown, we're also changing how we do our digital pathology. So I'm going to give everyone kind of an inside baseball look behind the curtain to show what it actually means to do the digital pathology and where do these numbers come from. So we start in 2012 when our young, spry medical students published this early paper that kind of cemented the University of Kentucky as not only an early adapter, but as a pioneer of digital neuropathology. And since then, we've kind of become a gold standard and a leader in this innovation. So they developed this workflow that I'll kind of walk through that begins with a whole slide image scanning of this piece of tissue, which then has there you go, these boxes that are placed in order to analyze them. And what we've found is that not only is this a really robust method of delineating gray and white in different layers, but also is a pretty feasible way to analyze the tissue. So we analyze the tissue in a couple of different ways. One of them is through burden. That's what you're seeing here. This is essentially, this is the density. So every one of these is being counted, as well as burden, where we get kind of a positive pixel count. Sorry, my computer is just a hair faster. There we go. So we get a positive pixel count that is used as a pathology burden number. And while this is great, it's labor intensive. It requires somebody to actually physically put those boxes there. And because of that, there have been better methods that have come out. So not only are we early adopters, but now we are kind of at the cutting edge of the newest programs and the newest modules that have come out. So this has kind of become my baby in the last 6 months, and I've developed this new workflow that I'll walk through. So again, it begins with this whole slide image. And from there, I've trained this AI detection software to detect what is tissue, what is glass, and what is meninges, which you can see here. So from that, it then does a quality control and looks for tissue that's in focus, tissue that's out of focus. Maybe there's a scratch or there's a hair or whatever, which you can see in red. So what it calls normal tissue, it then dissects out the gray versus the white matter.
Wow.
Again, this is something that had to be done manually or by a tech who had not only some objective view of the tissue and not cherry pick for areas of high pathology, but had to know, even a baseline level of knowledge when it came to different tissue layers and things like that. And then finally, it does this analysis. So again, we have plaques and tangles. There you go. Plaques and tangles. So obviously, plaques are on the left, tangles are on the right. So this is a way that we can count it, as well as our positive pixel, which, there we are. So again, this is all done automatically. So it doesn't require any physical input except for just clicking play. And it's done much faster, and it can be done overnight in the background while you're doing your other work. But what I'm most excited about is now we've integrated a really high level of artificial intelligence and artificial detection. So what we can see are the 4 areas that I've been working on. In the top left, this is phospho-TDP. Top right is phosphorylated tau. Bottom right is the amyloid. And on the bottom left are different vascular structures. And each one of these represents something that artificial intelligence can not only identify, but it can delineate and phenotype pretty rapidly. So now we can ask, okay, if there's a lot of tau, is that because there's a lot of tangles or because there's a lot of neuritic plaques? Similarly, we can ask, what does the vasculature look like in each of these different regions? What are the different phenotypes of the plaques, and so on and so forth. But one of the downsides of moving to a new method is that we have over 1,000 brains that we've been cataloging and analyzing. And what do we do with that data? Is it going to match our new system? Is it going to overdetect or underdetect? Are we going to have to go back and look at several cases? But what we can see, so on the left panel is our density measures, and on the right panel, we see our burden. But what's exciting is that you can see that our correlation between what Aperio, our original method, was detecting and what our new upgraded system is detecting is well north of 90% in all of them. In fact, in some of them, it's almost 100%. So not only have we developed a really robust method of identifying pathology that we've been using since 2012, we've now upgraded to one of the most modern versions of artificial intelligence and pathology detection, but it still is giving us a really robust readout of what we already thought. So this is, going to be a really nice, smooth transition that we're moving towards, and it really opens up our research for a lot of really cool opportunities. And that's all I got. And for the sake of time, I cut a lot out. So if anybody has any questions or would like to be involved with this, just please feel free to reach out.
Great. Well, thank you very kindly, Dr. Shahidapur. And again, people should contact him if they have questions or issues. But I wanted to take it sort of for a further ride, a little further spin, looking at the last few years' cases, comparing clinical pathological correlation and seeing, like, when the rubber meets the road, how these things correlate and what's the added benefit of using the digital pathology. We're going to look at the final mini mental state exam scores compared to digitally counted tangles versus Brock staging, which is the convention for pathological grading of neurofibrillary tangle pathology. For context and to orient you a little bit, so this is the R squared that Dr. Shahidapur showed before, is the coefficient of determination, which asks what is the percentage of the independent variable on the x-axis that is explaining the to what degree is the dependent variable on the y-axis explained by the independent variable on the x-axis. So how much is the MMSE score explained by this measurement of pathology? In a perfect 1.0, which you would never have but in practice, but this is what it would be in ideal situation, would be shown here. R squared of 1.0, it's 100% explaining. Whereas if it's 0, there's no correlation between the two. And so I'm going to show you then the last few years' cases comparing in the cases that lack late neuropathologic changes. So using Brock, you get an R squared of 0.46. Most of the action, if you're lacking late NC, is in Brock stage 6. And that's a pretty good correlation, pretty darn good correlation. But it's much, much better if you use the counted tangles, which are digitized, and you get about a 40% increase in your ability to explain the what we're interested in the first place, which is the cognitive decline of our participants. So I also looked at this for cases that had late NC, and you can maybe model it out in your head what it looked like. Here they are charted out in red, and what you can see is now there are Brock stage 5 cases that have low MMSE, and that is because they have low MMSE partly due to late, not just due to Alzheimer's disease neuropathology per se. You can see that there's a 5 to 10 point decrease in the curve of the MMSE for people that have late versus the people that don't have late. And it just sort of is a illustration that in either case, you get about a 40% improvement in your ability to predict cognition when you use the digital neuropathology, which is more graded, more granular, and less ordinal than the Brock NFT semi-quantitative score. So that just gives you a little bit of an orientation to what we do and why we do it. And with that, we will now move on to ADRC ID number 1271. Dr. Koskin.
Okay, so 1271, 83 years old. Her genotype, Apoyo genotype, is E2/4, and she has the maternal Alzheimer disease history. Past medical history is significant for B12 deficiency, depression, and anxiety. Not much the hypertension, hyperlipidemia kind, the vascular risk factors, but she was on antiplatelet treatment. So ADRC cohort entry was 2013 as the mild dementia due to Alzheimer disease. And she maintained that diagnosis throughout the 6 years that she stayed in our cohort. Seems like her presentation was actually started with the cognitive features as amnestic, initially amnestic MCI, then later actually progressed to more cognitive domains and progressive memory loss. So later actually she had executive dysfunction besides the memory issues. So the later the behavioral issues developed is depression, irritability, anxiety, sundowning, but there is no hallucinations actually reported. And the latest the development was the motor changes as she developed gait impairment with slowing and shuffling, some Parkinsonian features. So speaking of the exam, so overall her exam throughout the year is non-focal, but later transient right-sided weakness happened, but improved. So, and then the slowly had a multiple frontal release signs settled in. And as I mentioned, mild the Parkinsonian gait was noted in the reports. So she also, like our other patients, she was not really able to tolerate the memory medications due to GI side effects, and she was taking SSRIs to manage the symptoms. And then also she had a trial of citicoline and the Axona medical food during the cohort years. So the citicoline is actually a CDP choline, which actually helps the phosphatidylcholine, making a phosphatidylcholine, which is actually the membrane protein that helps to stabilize the neurons. But it was not really strongly associated or had benefit in Alzheimer's disease. So we don't really use this regularly. So the Axona is another medication that was used in the past, and this is the medium chain triglycerides. Apparently, the small study showed modest effect on the Alzheimer's disease. So it creates a ketogenic state, but it was not really strongly recommended for the regular use. But this person actually was given citicoline and the Axona. So throughout the years, the consensus diagnosis was Alzheimer's disease. The other factors probably contributing, non-contributing because it's treated B12 deficiency and depression and anxiety. So I couldn't find any epic entry, and I also have an access to the Frankfurt. So this person is Frankfurt. So I couldn't find any images in the Frankfurt database as well, Frankfurt regional database. Overall, based on the clinical history, I agree with the diagnosis as Alzheimer's disease. Before we process, so the last person has also the similar memory medication, he couldn't tolerate the memory medication. So I am guessing maybe this one also has some DLB, because in the DLB we see very sensitive people with the medication, especially any medication that we put on. So I'm curious to see what the pathology is going to show.
Great. So a long course of AD type dementia in this 83-year-old woman who also had gait impairment and question mark LBP. Dr. Harp, anything else to add to that?
Yes, her cognitive findings were fairly straightforward. She starts with an MMSE of 20, entered with dementia. All but her attention and processing speed were in the impaired range. And then by 2015, all domains were in the impaired range. So her final MMSE in 2018 was a 0. And this does suggest dementia with AD.
Okay, so an AD type picture plus minus Lewy body pathology in this 83-year-old woman. She indeed does have AD neuropathologic change, as well as some Lewy body pathology. She also has late stage 1, as well as having some cerebrovascular changes. So A1C2, these are her numbers, very, very close to a Braak stage 6. So this is very severe Alzheimer's disease, compounded by having some Lewy body pathology and some late. This person has late stage 1, which means that it's only in the amygdala. So that raises the question of, does that matter? Is that incipient, or is that of enough severity to be correlated with cognitive impairment? To address this question, I point you to this paper by Woodworth et al. That looked at NAC data and compared people with stage 1A, which means that it's only in the amygdala, stage 1B, which means that it's only in the hippocampus, stage 2 means it's both amygdala and hippocampus, and stage 3, which means it's in the amygdala, hippocampus, and the middle frontal gyrus, that it's permeated through the brain much more thoroughly. So this is what the data look like. And comparing the different late neuropathologic change stages to people that don't have any late. And what you can see is that even stage 1A and 1B have an odds ratio that's greater than 1. At 1, it would be the same. And these lines here indicate the 95% confidence interval. So it satisfies the criteria for being under the threshold of p less than 0.05 that we mysteriously always use as scientists to designate something being significant or not. And it does become more and more higher associated with dementia and with memory loss, the increasing stage. And to give you sort of a background of how this correlates with other pathologies, it is commensurate with an intermediate stage of Alzheimer's disease neuropathologic change. A more severe high level of Alzheimer's change is more impactful on both dementia and memory than late NC is, whereas Lewy body pathology is less impactful either on global dementia or memory in comparison to late NC stages 1, 2, and 3. So this just gives you an idea of the order of magnitude of the impact of the various pathologies and the various stages of them. And this person sort of is an overlap between Alzheimer's pathology, some degree of late, some degree of Lewy body disease as well. So there's another complex picture from the pathologic standpoint that was also reflected in the complex picture of her clinical mixed symptomatology. And so you were right, Dr. Koskin, that there was some Lewy body pathology there. And
I wonder if we should use that as a diagnostic criteria, having a sensitivity to the memory medication in consideration, actually. So
we can do that study. We can do that study. We can do it retrospectively.
Let me just clarify for the group out there. We see actually a very low likelihood of intolerance to acetylcholinesterase inhibitors because the side effects are driven by autonomic function, which is depressed in people with Lewy body disease and Parkinson's. We do see a higher sensitivity to memantine and other medications, but the cholinesterase inhibitors actually are extremely well tolerated in Lewy body disease and are extremely beneficial. So you have to separate out your memory medicines. I don't want to give people the wrong idea. Lewy body disease is highly symptomatically treatable.
I wonder whether it's like the cholinesterase inhibitors, maybe like if they have a systemic hypotension or like it doesn't really affect much the blood pressure, but heart rate. But as you said, they tolerate okay.
Well, we could do the study. Just we got the data in the hopper.
True. And I was going to ask you one last thing, actually. So does that mean that the late could start either way, either the amygdala or the hippocampus? But if it is in amygdala, seems like it's much more significant to go to, like, spread?
It can start either way, and there's also the problem of how we detect it, how we sample it, and it's probably that when we see it in one place but not the other, that in a certain number of cases they were just missing it in the other one. So it's not just that it's there or not there, it's just do we detect it? And it turns out that the people that you just detected in one and not the other are probably just the ones that where the severity overall of the pathology is more subtle and sparse.
So when you say detected, it is an immunostaining, right? So it is there or not?
Correct, but just because you sample this part of this
I see.
hippocampus, you can be missing it all. Yeah,
I see. Got it.
Looking at a very narrow target zone.
I see.
All right, so with that, we'll go to ADRC ID number 1184.
All right. So this one has an image, and I have some of them actually is animated. So All right, so 1184, this is a 82 years. And this person, unfortunate E4 and 4, maternal Alzheimer disease history is noted. Past medical history is very benign, only the prostate hypertrophy. So this person actually entered in our cohort in 2019 as a amnestic multi-domain MCI, maintained the same diagnosis for 2 years, then progressed to dementia over the last 2 years that he stayed in our cohort. So his course was also gradual decline, become dependent on driving, later on managing medication and finances actually noted, and progressed to ADL dependency later in life. So the last year, he was still able to dress and bath independently and ambulate with a cane, but depended on the rest of the ADLs. Towards the end of the last 6 months, he developed seizures as well. So his course, his domains actually started with cognitive features as initially isolated word finding problems even before his entry in the cohort in 2017. That progressed to have multi-domain amnestic deficits with the executive dysfunction and inattention, and gradually progressed to all the domains in memory lost over time. So then he developed motor symptoms in 2021, quite a few years later than the memory problems. And subtle signs actually was noted in the exam in 2019, as he was talking with soft voice as well as not really conversant with the interviews. So and also, where was I? He is actually a very exercise savvy person. Apparently, he was running lifelong running, and in fact, until the 2021, he was running regularly. And behavioral issues. Interestingly, no behavioral issues reported, no hallucinations that I have seen in the reports, and I checked also EPIC, no RBDs and depression, anxiety, or agitation. So in terms of the exam, I put it in specific years to show you how he progressed. Year 1 in 2019, he had a soft monotone voice. 2020, he developed postural hand tremor with left dysmetria. Apparently, the third year, he started having full-fledged, we call it exactly the Parkinson disease exam, as stiffness, rigidity, bradykinetic gait, idiomotor apraxia is not really part of it, but also it shows the progression of the disease, micrographia, but no resting tremor was noted. Still, essential tremor was observed with the left grasp reflex as the frontal release sign. Year 4 and 5, he got much worse in these symptoms. And we apparently refer this person to movement clinic. Dr. Ali followed this person 2 or 3 times. And last year was much more Parkinsonian findings that was noted with the cortical signs, basically. And then he has, besides the frontal release signs, impaired left-right discrimination at the end. So the treatment-wise, initially could not tolerate the memory medications again, another one, both donepezil as well as the memantine. He had to stay in donepezil 5 milligram. We couldn't really increase to 10 milligram. He tried Sinemet. He was poorly tolerated, and because of that, he declined to use, I think. And then we tried memantine. He was not really tolerated that either. So last year was managed with the Pramipexole. Sol. He had some benefit from that, which is actually dopamine agonist. So the last year he had seizure activities and started on VPA. So etiology-wise, we initially considered as an Alzheimer disease. Later, we considered as PD dementia, Parkinson disease dementia versus DLB. So the other contributor factors, I think, big impact of the E4, but there is no other vascular risk factors or anything that I can pinpoint. So interestingly, the EPIC notes in Dr. Ali's notes, he never actually coded his diagnostic ICD code as Parkinson disease, recorded as MCI with Parkinsonian features. So I'm not sure what his thought process, but DLB was not mentioned. So, and now we have seen him in KNI 2 months prior his death, apparently. If we go to the images, I can talk about the images. Okay, so as you can see, I have few sections as the coronal T1s and then axial T2 flares, as well as the sagittal images. So can you click on the one by one? I'm so sorry that I'm going to ask you. So you can see hippocampal atrophy, very significant bilateral with the interesting, so impressive gap with the collateral sulci actually being prominent. So can we proceed? So this, as well as you can see the global atrophy with these sulci being prominent. If we go forward, so confluent white matter diseases in the axial T2 flares that you can note it here. Please go forward. And then you can see the posterior atrophy, which is one of the signs of Alzheimer disease features. If you go forward, there is also either you can call it megacisterna magna or the subarachnoid cyst with possible cerebellar atrophy that I can see those filias really clearly on here. Can you go forward? And then you can see this is a 20 years old guy with a very thinned out the corpus callosum. Overall, every area that actually being thinned out. So probably that related, we were talking in the beginning, with Dr. Jaika. So it could be vascular related thinning. And then go forward, please. And then you can notice, can you push one more? The enlargement of the ventricles with the global atrophy, suggesting a ex voco dilation. So the diagnosis is, I listed here, Alzheimer's disease. I'm not sure whether he has DLB. Most likely it's going to be DLB synucleinopathy, but I also consider vascular Parkinsonism as well. So there is small vessel disease, as you can see, a lot of white matter, confluent myveters. And then the progression with the, given that the hippocampi are so small, I consider late pathology as well.
Thank you kindly, Dr. Koskinen. That was a nice presentation. Dr. Harp, anything to add here?
Oh,
This 82-year-old man with E4, and an AD type dementia and Parkinsonism.
right. Yeah, he started with an MMSE of 25, entered with MCI. He was amnestic. He was dyspraxic. He had low processing speed, and also his speed at executive functioning was in the impaired range. His fluencies remained borderline until 2022. So there is some possibility that we're seeing a late profile there with the fluencies holding steady versus memory. His trail speed and object naming did decline as well. His final 2023 MMSE was 19. And you can see this profile matches up quite well with what Dr. Koskinen presented. So we call this dementia the Alzheimer's disease. There is a question of whether it's vascular Parkinsonism versus a synucleinopathy, given the dyspraxia was there. And then also his digit span started to decline, which oftentimes we'll see with the synucleinopathy.
Great. Okay, so this 82-year-old man with E4 genotype, AD type clinical picture has indeed AD of severe nature. There was brainstem Lewy bodies, and there was no late. There was acute pale infarct in the occipital lobe, and some chronic changes. I'd say A2, C2, Dr. Abner. The severity of the tangles were not quite as high. I'm a little bit surprised that there wasn't late, given the severity of the hippocampal atrophy in this case and some of the clinical features, but such was the case. So we have a high level of ADNC, predominantly brainstem distribution of Lewy body pathology, and I don't think it's unlikely that there was a contribution to the Parkinsonism from the vascular changes. But that's the picture of a severe AD neuropathology.
I wonder, as my mentor always says, maybe the vascular changes that is causing that much hippocampal atrophy, right, Dr. Jacob?
So, I'll point out one thing on that, that actually, you have to blind yourself because there's enlargement of the temporal horns of the lateral ventricles. There indeed is hippocampal atrophy there, but it's not super severe for an advanced Alzheimer patient. And so this is, what we're working on with late. How do you make that call that this is greater hippocampal atrophy? So I do think he has a large degree of generalized atrophy, reflecting in that temporal horn enlargement, which makes the hippocampi appear quite small. But if you look at it, most of the atrophy is in the head of the hippocampus. As we move laterally into the bodies, we see a thicker hippocampi. Although there is entorhinal cortex atrophy clearly seen as well. So this is difficult. We're still using judgment calls. We haven't worked that out well. I did, and I'm sorry, somebody came and interrupted me when you were showing the slides. Did we see evidence for microhemorrhages on the imaging?
No, actually, vascular changes that I would consider actually look for ACAA. No, I don't know actually. I should say that we don't have a GRE.
So this is something always that's of great interest for those that are interested in CAA. Pathology picks up 100% of CAA. We use the Boston criteria. Pete's shaking his head. I have faith in neuropathology, Pete. We use the Boston criteria, which is based on microhemorrhages on the MRI scan, but we actually only capture about 20% of CAA using Boston criteria. Its specificity is fantastic. Its sensitivity is absolutely horrible. So this is just a shout out to Dr. Barani, who's working on new imaging techniques for the detection of cerebral amyloid angiopathy in life. And what a serious need this is when we have a pathological entity that's contributing to a disease course, and we can only detect it in 1 out of 5 people that have it. That's horrible.
You pointed out something, actually, it is interesting. The late diagnostic criteria, I wonder is there a study? Probably there is a study, but if not, would it be the wise to do ex voco dilation measurements with the hippocampal atrophy? So global atrophy normalized to the people's hippocampal atrophy, that would give us much more confident late diagnosis, maybe. Dr. Nelson, Dr. Jaika?
So I don't know if there's a study like that, but there certainly are qualitative studies that have been done, and that's built into the original Shelton's criteria for looking at hippocampal atrophy. Is you must look at the entorhinal cortex, the hippocampus, the collateral sulcus, the parahippocampal gyrus, and the global atrophy and the temporal horns of the lateral ventricles, because all of those have to be put together. So I do think there's work that needs to be done, and we know that this is an active area of exploration, refining what we mean, because the consensus criteria does indeed say hippocampal atrophy out of proportion to what one would expect for AD. but we really haven't put guardrails on that. It remains a clinical judgment per se, and we do need to define this better, Pinar. So it is an area where we certainly could contribute and is worthwhile to look at anyway with some of our volumetric measures.
Yeah, and we have the
Okay, moving right along. I just got to go from here. The one more other thing I would say is that ApoE4 people always have CAA as a general rule. ApoE4 drives the heck out of CAA. So next person is 1059, Dr. Koskin.
Sure. Okay. So this one also has images that we are going to look at it, appreciate it. And this is 86 years old at that. Again, another ApoE44 with the familial history. So this person has quite a bit of the vascular risk factors as former smoker, COPD, CAD, cardiac, the CAD, hypertension, hyperlipidemia, pre-diabetes, obstructive sleep apnea, and some other little things that is actually in the history. So this person came into the cohort in 2011 as a amnestic MCI. But interestingly, when he entered the CDR was 0 in the. Actually, here it shows 0.5, but when I look at the database, it is all 0 until the 7th visit. So I don't know the discrepancy, but the maintain the same diagnosis throughout the 12 years. So the course of his progression is slow and gradual decline. He always have a subjective memory problems and always rely on written notes to himself and stayed independent throughout the 12 years old history. So the later more cognitive issues settled in as inattentiveness and some more language problems, executive issues, but able to manage his life without much help. So the last 2 years, he lost his wife. He had to live alone. And then those times, even he entertained to go back to work a little bit. So he was sort of independent throughout the years of 12 years, very long course. So in terms of the domains, seems like the cognitive features are dominant, persistent subjective memory problems initially and progress to other cognitive domains, but motor symptoms was very mild peripheral neuropathy, nothing marked as Parkinsonian, nothing marked as ataxic, so no motor the findings that was reported. And the behavioral, he didn't really have anything that reported, no even depression after his wife died. He had some grieving, but nothing really mentioned. So in terms of his exam, consistently he had frontal release symptoms of the palmomental, but it is only one of them was reported. So, and mild essential tremor, but no Parkinsonian features or ataxia. And in terms of his management, he was on donepezil and memantine throughout the years, and his risk factors were well managed with the medications. So the etiology considered as Alzheimer's disease all these years, he has a amyloid PET scan in 2015, and it was negative then. Other contributors as E4 and vasculopath that I mentioned, so some of the concerns for vascular dementia. So the EPIC entry, he has quite a bit entries, regular visits though, nothing really related to memory. In last year, he acquired I think the 4 months before his death, acquired the COVID-19, developed secondary infection, MRSA infection in the lungs. He had to go through very invasive procedures and very heavy antibiotics. But towards the end, he opted out to go to hospice care, and he lived 2 more months at home. And he died of, I think, the complication of the severe COVID infection. So if we go to the next one with the images. So here again, you have seen, you are seeing it, the T1 coronal and T2 axial flares, as well as the sagittal view. If you could push one, then you can see the hippocampal atrophy. So you can also appreciate some the brain volume loss as the ventricles are bigger, and in fact. It is more like it's a little bit more asymmetric, as on the left side is more atrophied in the hippocampus. And then next one, so you can appreciate the posterior atrophy as the one of the atrophies that we see in the Alzheimer disease. If you progress one, you can appreciate also, as I mentioned, the ex-vocal dilation, but it is not as impressive as the other one. So if you go one more. So we have few lacunar infarcts that I actually pointed out. The last one was a little bit questionable, but it is in the hippocampus, and there is some glial gliosis that I see. I think it's a real one, and I have seen some around the basal ganglions as well. And now you can see some cerebellar atrophy. So the diagnosis, as I considered, I'm sorry, it's just not so Alzheimer disease is unlikely that I say, but the pathology is very much like Alzheimer disease, the images. So I consider late a lot, and very the small vessel disease because of the lacunes.
One sec. Thank you very kindly. So we have an 86-year-old with MCI, and take it away, Dr. Harp.
Excellent. Okay, and I'll just kind of take these in order. He started with an MMSE of 26, and as we heard, entered with an MCI, although the CDR scores were a bit interesting in the database, but MCI with a low story memory, but his wordless memory was okay. So in that top graph, just to reorient people, we have the year of the visit along the x-axis, and then on the y-axis, we have a z-score. So that is a mean of 0, and it is a standard deviation of 1. What we tend to consider borderline is right around negative 1.5, but there's a little bit of a range around it. And then below -2 would be what we consider impaired traditionally. And all of that shifts depending on the pre-morbid ability of folks. But if you want to see, actually, I just had someone, okay, Justin pointed out in the chat, this is perfect. The blue line in the first graph, story delay, you can actually see this person slowly getting better over time. And we put that down to a practice effect. What's more interesting is that the verbal memory of using just a word list, which is the orange line, is not impaired at all. It's totally fine and remains so over time. So what we're seeing is somebody who in a more complicated learning and memory situation, struggling, but of course improving with practice. Figure memory was a bit different. It sort of starting in 2016, it's fluctuating until the end. Looking over to the right at language, also an interesting pattern. In Alzheimer's disease, what we usually see is that semantic verbal fluency, so naming things in a category, is generally lower than phonemic verbal fluency, which is naming things based on the phoneme or the letter that the word starts with. This is the reverse. And so this would be a more typically vascular profile where it's the phonemic fluency that's in a borderline range most of the time, and it's the semantic fluencies and object naming. So what we look for dysnomia, they remain normal all the way through. And then looking at the third graph, we've got speed and executive function. The dark blue line is speed doing digit symbol coding. So basically just changing a number to a symbol. And then the orange, I would consider that very low score in 2017 to be an outlier. So ignoring that, the trail speed stays normal. But the speeded executive functioning, that TMTB, the green line, is fluctuating very considerably. And so What we came away with here is that it seems like the cognitive difficulties they look more driven by cerebrovascular factors. But, as we saw, it's very likely that there's Alzheimer's pathology as well. It just didn't seem to be driving much of his cognition. So in the end, he had a final MMSE score of 25. So not much of a change. We called this MCI with cerebrovascular and Alzheimer's contributions.
Great. Well, there are some really interesting things about this individual. For one thing, he was ApoE4E4, and he died at the age of 86 with a long-standing MCI, which is not the usual history for an 86-year-old with ApoE4E4. And secondly, he was on band 2401, which is lecanemab, basically,
Correct.
right?
Yes.
So he was on an anti-A beta immunotherapy, and it really based the question.
I don't think that he did. So his scan was negative, so he never made it to the study.
Oh, I see. So he was a screen fail.
Yeah.
So he was somebody that was ApoE4E4.
I think we should check that and make sure if he was in the phase 2 study, that might have been a post-trial negative. So we should clarify that before we make assumptions.
Justin, can you check that?
Absolutely. Because he really had a very moderate amount of pathology for an 86-year-old who had ApoE4E4. And the longstanding MCI is not normal. So this person had the intermediate severity of AD neuropathology change, had late NC stage 1, which we've seen is correlated with increased risk for dementia and for memory problems, had vascular pathology with chronic 2, acute 0, a fairly subtle amount of pathology, had the A beta plaques, but not really the neocortical tangles that are associated with cognitive impairment, giving him a Brock neurofibrillary tangle stage of 4 with some A beta plaques, but nowhere near as much as you would think for an 86-year-old with ApoE4E4. So this person had passed away in the MCI phase, had the one thing that I would say was very conspicuous was that he had an unexpected brain mets with carcinoma. So he died of cancer, nothing to do with his cognitive pathology otherwise.
What is the object of cancer?
I would say, so this is where he goes in our schema. Let me say he had a history, I guess, of prostate cancer. Mm-hmm. This is what his brain looked like looking at his basal ganglia. So you see the putamen on the left, the globus pallidus on the right, and you can see this big bunch of stuff that is not normal. It's cellular, going up higher to moderate magnification. You can see this very cellular material. On the left, you can see the relatively normal-ish white matter. On the right, you can see this profusion of cells that are not normal at all. If you go to even higher magnification, you can see what the cells look like. They're extremely anaplastic, atypical. Here on the right, you can see these structures here, which are blood vessels, and you see the cells coming out, streaming out of the blood vessels like pirates coming out of a pirate ship or onto a normal ship. And unfortunately, these dreadful, large, nasty, anaplastic, and very atypical looking cells also have these structures, such as this guy here, which is a tripolar mitosis. There are many, many different mitoses in this one little microscope field. These anaplastic, large, bizarre cancer cells are dividing. They're dividing very actively, and they are proliferating. So they're not only boarding into the nervous system, they are dividing and expanding their cell population. When you back off from the high magnification to the moderate magnification, now you can see, you can appreciate on the right, upper right, this cellular free region of dead cells. It's called necrosis or dead cells because the tumor has outgrown the ability of it to vascularize itself and to nourish itself. So it's part of it's dead. And so we have a person here who died of cancer And despite having a fairly high burden of sort of a preclinical burden of pre-dementia pathologies. So I think I'm going to exercise my prerogative and stop here because Dr. Abner has to go and it is 11. So we'll take the next one, we'll do the next month, but we this is basically what we saw of the 4 of the 5. We saw a group that had complex pathologies, but none of them were pure AD, and they usually had a complex combination of pathologies to go with their complicated neuropathologies. So thank you very kindly. Thanks everybody for your
I will add
attention.
on actually. I'm checking on the database. It says bank 2401 pre-screen failed, ahead pre-screen failed, A4 pre-screen failed.
So he was a lucky person neurocognitively then, in terms of he must have had some mechanisms that were trying to make him relatively resistant to the pathologies with the ApoE4, E4 genotype.
Interesting.
A resilient individual. Okay, thanks everybody.
Thank you. Dr. Shahidapur, well done. Fascinating.
Thank you.